Thank you very much, Zainab. My name is Zina and I will be discussing the management. Dental management of patient with bleeding disorder. First of all, we ask about the history, the relatives, bleeding problems after operation or teeth extraction. Maybe if the patient taking certain medication like aspirin, or maybe he's taking anticoagulant drugs, or have present disease like leukemia, liver disease, or hemophilia. Clinical examination, we should check for jaundice, spider angioma, oral ulcer, and we should check screening laboratory test, which I will be discuss later. Surgical procedures, excessive bleeding after surgery may be first sign. We could see here a clinical picture of the spider angioma. Hemophilia is a bleeding disorder where the blood does not clot normally because it lack of sufficient clotting proteins or clotting factors, mostly factor VIII. Now dental management. Block anesthesia, lingual infiltration or injection in the floor of the mouth, and intramuscular injection should be avoided unless we do the replacement of the factor. And we have infiltration anesthesia, intraligamentary injection could be given without factor replacement, and also orthodontic treatment, root canal treatment without over instrumentation, and polishing could be done without factor replacement. Preoperatively, we consult with the hematologist to confirm the diagnosis. If mild to moderate, could be treated in the dental clinic, but in severe cases should be treated in the hospital. And as my colleague discussed with you, we use the gel foam with thrombin to control bleeding, splint for the patient with multiple extraction. Post-operatively, the patient may need the second dose of factor replacement, and we should avoid the use of aspirin and non-steroidal anti-inflammatory drugs. Gel foam goes socket and thrombin. This is a picture for stopping the bleeding, and I will leave you with a video of von Willebrand disease.
There's a break in the wall of a blood vessel and blood leaks out. Platelets collect around the break and become activated, changing their shape and forming a kind of plug that blocks the break. But those platelets need to be brought to the cut and to be kept there. This is where von Willebrand factor comes in, and fibrin. Let's imagine that platelets are like fish swimming in a river. Von Willebrand factor acts like a fishing rod, hooking up the platelets and bringing them to shore where there is a leak in the riverbank. Fibrin works like a fishing net that's put down near the leak to get all the fish together so that they block the leak. People with VWD have low stores of von Willebrand factor. In other words, very few fishing rods, and they're usually kept locked up in a shed, which means there aren't enough fishing rods at the riverside, and so not enough fish can be caught and reeled into shore to block the leak. So, the water continues to flow out.
Dental management of von Willebrand disease. Mild foam surgical procedures can be done in the dental clinic without the decompression and EACA, which stands for E-aminocaptoic acid or tranexamic acid. More severe cases require factor VIII construction. Dental management established for good oral hygiene, platelet splint, as my colleague said, and treatment of acute infection. Post-operative patients should be checked or examined 24-48 hours. If there is any bleeding, we should use tranexamic acid or EACA. Dental management of thrombocytopenia. When it counts 30,000 cubic millimeter, infiltration and block anesthesia can given. Also, almost routine dental procedures can be performed. 50,000 cubic millimeter extraction dentinoalveolar surgery can be done. More advanced surgery will need 80,000 cubic millimeter or higher. The use of tranexamic acid again and EACA minimize the need for the platelet replacement. Acquired bleeding disorder. The main cause include anticoagulant therapy. These are given as prophylaxis or treatment of thromboembolic events like atrial fibrillation and pulmonary embolism. The common drugs are warfarin and heparin. Warfarin is the most commonly used oral anticoagulant. It's a vitamin K antagonist. Warfarin inhibits the vitamin K-dependent synthesis of clotting factors such as factor 2, 7, 9, and 10. Its effect began after 8 hours and persists for 72 hours, result in prolonged PT and INR. Warfarin, there is drugs enhance the effect of warfarin, such as non-steroidal anti-inflammatory drugs and amoxicillin, and its effect reversed by vitamin K. Heparin is a natural product that is present in the granules of the mast cell and released when there is an injury. It's also used as a parenteral anticoagulant given subcutaneously or intravenously for acute thromboembolic episodes like surgical procedures to prevent deep vein thrombosis and pulmonary embolism. Heparin acts immediately on the blood coagulation to block conversion of fibrinogen to fibrin. The protamine sulfate acts as reverse effect of the thrombin. Acquired bleeding disorders. Scurvy. What is scurvy? Scurvy is a condition characterized by general weakness, anemia, gingivitis, gum disease, and bleeding, and skin hemorrhage caused by prolonged deficiency of vitamin C. So, as I said, scurvy is vitamin C deficiency and it affects the normal synthesis of collagen and result in a bleeding disorder characterized by petechial bleeding, bruising, and subperiosteal bleeding. The key of the diagnosis is the dietary history. Laboratory evaluation, we have platelet count, bleeding time, prothrombin time, partial thrombin time, and thrombin time. Platelet count, the normal value is 100,000 to 400,000 cells per millimeter, and less than 100,000 will be the degrees of thrombocytopenia. Bleeding time, provide the assessment of platelet count and function, normal value 2 to 8 minutes. Prothrombin time, measure the effectiveness of the extrinsic pathways, normal value 10 to 15 seconds. Partial thromboplastin time, measure effectiveness of the intrinsic pathways, normal value 25 to 40 seconds. Thrombin time is the time for thrombin to convert fibrinogen to fibrin, a measure of fibrinolytic pathway, and its normal value is 9 to 13 seconds. Management of bleeding in patients with uncontrolled hypertension. This group of patients need appropriate medical consultation for initial of the medical treatment to decrease their blood pressure. Thus, once the blood pressure is controlled, then the bleeding decreases, and with the local measures, the hemorrhage is controlled. So this is a summary of the type of bleeding, cause, and management. The primary occur just during the surgery, and it's easily managed by securing ligation and the pressure swab to achieve hemostasis and the use of hemostatic agent like Bonmax and Sarjocid. Intermediate reactionary hemorrhage, this type occur within a few hours after the bleeding, result of the failure of coagulation to occur, such as in patient with systemic bleeding, as we mentioned before. The preoperative care of underlying deficiency of the platelet and proper replacement of the factor should be done. And secondary hemorrhage, this occur after 7 to 10 days after the surgery, and this is due to infection. So the management will be removal of any development of the wound that promote the infection of the wound. The webinar will be ending here. Thank you for your kind listening.